So thank you, Sue, for the warm introduction, and delighted to be with you all this evening. I'm just the other side of Manchester, actually, and it's been fairly sunny today, which is quite unusual for Manchester. So what we're going to talk about today is women's experiences of post-traumatic growth after a traumatic birth. And this is a joint presentation between the three of us, and Rhianna led on this research for her PhD and her doctorate in clinical psychology. Next slide, please. I'm just going to kick off with looking at, just explaining really what PTSD is, looking at the concept of child-related PTSD, which is post-traumatic stress disorder, and just thinking conceptually about traumatic birth and what it might be and what it might entail. Next slide, please. So just a content warning before we start. We are going to be talking about sensitive issues, like abuse, traumatic birth, psychological problems that might ensue. So it's just to give you a warning that we are going to address some sensitive topics this evening. Next slide, please. So just looking at post-traumatic stress disorder following childbirth. Previously, it was viewed as an anxiety disorder, and now it's related to more of a stress or trauma-related disorder. And approximately 2 to 3 in 100 birthing women will experience childbirth-related PTSD. There are higher rates in more complicated births, so you go from about 3 to 5% to 18%. And the rates in trans and non-binary birthing people are not known, but a recent review by Greenfield and our own Zoe Darwin suggests that the rates might be higher in these particular groups. So it may follow a traumatic birthing experience, or a miscarriage, or stillbirth, or neonatal death. But the important thing is it's not necessarily related to the objective perception to the extent of the trauma. The trauma can be subjective, so it's not particularly related to what we might perceive as certainly as midwives, as a traumatic experience. It's very much from the subjective perception of the woman. And just to say that in this presentation, we are referring to women because that's the language that's used in the evidence and policy documents, and also Rhianna interviewed women for her study. But we do recognise that all people who birth are not all people that birth are women, and that all women who are parents have not necessarily given birth. So that's the context, but we are going to use refer to women. So I'm not going to say too much about treatment because this is not the focus of the presentation, but just to say that there is particular psychological treatments that can help with childbirth-related trauma, including trauma-focused CBT and eye movement desensitization reprocessing. These are effective treatments, but psychological treatments are quite difficult to access. And not everybody will get access, and not everybody will get a working label of childbirth-related PTSD that will allow them access to effective therapies. And also the timing of the treatment is debated, because for some women, after a birth event that's traumatized, it could spontaneously remit in about 3 months. For other women, the trauma response comes later. So the timing of when you actually seek treatment or gain treatment is much debated. But helpful things that can be supportive are a debrief with an empathetic health professional, such as midwives, obstetricians, maternity care support workers, is somebody who really can maybe contextualize the event for the woman, but also really believe her story and listen to her story and her perceptions. And most women will talk with partners, family, friends, those who've had similar experiences. And there are online support groups like the Birth Trauma Association which can provide support and help and resources. Next slide, please. So what is childbirth-related PTSD? Well, it's a relatively new concept, which has evolved over the last few decades. And it's now argued that trauma related to childbirth is not generic PTSD, but rather it has unique features, it's a unique subtype. And interestingly, it's been seen as previously not eligible for a traumatic event. So birth was not viewed as a type of event that would produce trauma. And as a midwife, I haven't practiced for many years, but I remember my clinical days very well in bearing witness to very traumatic births and women reporting traumatic births. So it's very interesting to see that it was late to the classifications in like ICD-10 and DSM, which are psychiatric classifications, that birth was not viewed. And you reflect on why is this? Well, birth is seen by society as a socially positive event. So it's almost not supposed to be negative. So it's difficult for women to then talk about birth and reconstruct it as something that is negative and has affected them in a detrimental way when society is viewing it as a positive event. And it's probably one of the only sort of trauma areas where it can be considered a positive event as well as a negative outcome. And because it's centred on women who've given birth or had birth experiences, the effects very much go across family systems. It's a very debilitating condition. It affects women's psychological well-being, their physical health, and their overall quality of life at a time when they've got a new baby, they're trying to bond with the baby, provide for the baby. So all this trauma response can interfere with bonding. And also the baby, because the traumatic event was around birth, the baby can actually act as a reminder for the trauma. Next slide, please. So I just wanted to talk about the main symptom clusters. I'm going to start on the left-hand side of the screen. So these are the sort of symptoms that people report experiencing, maybe not all together, maybe some of them. So re-experiencing the event is very common, going over and over the event. And this can happen with flashbacks, which can happen at any time. A woman can be going for a walk in the woods or watching a particular TV program, and something makes that event come back. And it's very startling, it's very real. Women can also experience nightmares and night terrors. And then looking at cognitive behavioural avoidance, avoiding places, avoiding people that might be associated with the event is common. Hyperarousal, people report being in a state of always on edge, feeling that the heart rate is rising, feeling panic, feeling anxiety, a really high state of fight and flight response. And then also negative alterations in mood and cognition. So women can feel low, tearful, depressed, have suicidal thoughts, feel anxious, irritability, and often stress and anxiety will display itself in somatic symptoms like gastrointestinal upsets, headaches, and other symptoms. And all this is going along as can be affecting the bonding with the baby and particular effects on personal, intimate and family relationships. Next slide, please. So, but looking more broadly, let's think about traumatic birth, not necessarily as PTSD, because traumatic birth is a very complex phenomenon and any birth experience can be traumatic. I like this sort of definition, if you like, from Greenfield, that it is a birth that's involved events and or care that's caused deep distress and disturbance to the mother, and the distress has outlived the immediate event. So it's not necessarily that there's any particular physical harm to the mother or baby. It can be a traumatic birth, like a Keelan's forceps, third-degree tear, or the baby could be injured, like in shoulder dystocia, but it's not a necessary prerequisite. And there's a need to recognise the impact of interactions with midwives and other health professionals that deal with women in maternity services, because the way that health professionals and midwives respond to women, help them understand these difficult events, also impacts, and women often will quote years later particular words that a midwife or an obstetrician has said to them almost verbatim because it was so upsetting. So we do get a number of women that are diagnosed with childbirth PTSD and fulfill the particular criteria, but many more women have subthreshold symptoms. And that is that the symptoms might not be enough to constitute a definite diagnosis, or they might not be severe enough, but they're still extremely distressing and have effects across women's quality of life. Next slide, please. So what could make a birth traumatic? Well, there was some seminal work done by Cheryl Beck, where she asked women to tell their birth stories. And this was back in 2004. And really, it was one of the first pieces of work that really listened to women's stories. And that there was a huge range of experiences and that are all valid and should be treated as valid. And some could be that the woman felt that she just wasn't listened to. There is an increased risk in vulnerability in certain circumstances. So where there's maternal neonatal mortality or morbidity in this or a previous pregnancy, certain interventions can be traumatic. And people who have had a previous trauma, including a history of sexual violence, abuse, history of childhood abuse, adverse childhood experiences, are more likely to experience childbirth-related trauma. And it's also common in very specific groups, like in forced migrant groups. And as Sue said, we are still in the grip of COVID, and the rates are rising again. And it's likely that perinatal mental health, that we're sitting on a time bomb here, because through the pandemic, women and their families have been affected by COVID during their routine interaction with maternity services. So, giving birth when people are wearing masks, birth in environments where feelings and risk is heightened during COVID, and maybe not having restrictions, so not having your chosen birthing partner with you, which must be extremely frightening, and also not having support during things like scans, because sometimes a scan is a negative outcome rather than a positive outcome. It could be that there's fetal death in utero or an early miscarriage, and there's nobody with you at that particular scan. Next slide, please. So I'm just setting the scene here for Rhianna's work, because in summary then, we can see that childbirth-related post-traumatic stress disorder can manifest itself through a range of responses. And of course, it may be missed because we don't routinely ask maybe about trauma, and it can be incorrectly thought of to be like postnatal depression. And the impact of childbirth-related trauma can be years later. Trauma can lie dormant, or it can be re-experienced later with particular triggers. So it is not necessarily it's contained to a certain time frame post-childbirth. And then there's possible impact on future reproductive choices, such as secondary tocophobia. So a really negative experience and traumatic experience can bring a fear of childbirth or experiencing pregnancy or childbirth in the future.